That's fine. So when Ron arrives, this is waiting for him.
Unless they already sent it to him. Okay.
So it's the same thing she has asked for rehearing, right?
Yes.
Second hearing.
Good morning, everyone.
Good morning, sir.
Good morning, sir.
Good morning. Good morning.
Hello. അല്ല ഒന്ന് ഞാൻ ക്ലോസ് ചെയ്തായിരുന്നു മ്യൂട്ട് ചെയ്തായിരുന്നു ഇപ്പം കേൾക്കുന്നുണ്ടോ ഓക്കെ അല്ലേ ഇറ്റ്സ് ഓഡിബിൾ റൈറ്റ് ഓക്കെ Hello. Hello.
So we can hear you, sir.
Yeah, thank you.
Jayendra, good morning. You can start your presentation.
Good morning, sir. So today I'll be giving a talk about the complex knee injuries conference that happened in Jaipur. Actually, this is the second conference that is happening in India.
Jay, we are not able to see any of your presentation.
Is it, sir? 1 second, sir. Sir, is it visible now, sir?
Yes, yes, yes. Now it's visible.
Yes. So, good morning, sir. Today I'll be talking about the conference that I attended in Jaipur, that is complex knee injuries. This is the second conference about this complex knee injuries happening in India. First was in 2019. So, the organizing secretaries for this conference are Dr. Robert Leprad and Dr. Roshan Vade. First, I'll be talking about a few things which happened uh, during the conference. So, I could meet Dr. Nicholas Antoi, who is a good friend of Dr. David V. Rajan, sir. And I met Dr. Febin, who was our ex-fellow. And Dr. Antoi introduced me to Dr. Raj Kumar, who is practicing as a consultant arthroscopic surgeon in St. George's, Bangalore. To my surprise, he told me
Oh,
that
that's
he was
Febin, is
also
it?
David Rajan sir's fellow. Ah, yes, sir, Febin, sir. And Dr. Antoi, sir, introduced me to Dr. Rajkumar, sir. So he told me that he was
Jayendra, you're
also
not
David Rajan
audible.
sir's fellow. Is it, sir? Sir, is it audible now? Sir, is it audible now?
You're audible, Jay. I think Sir's mic is turned on.
Okay.
You're audible. You're audible. Please proceed.
Okay, sir. So I met Rajkumar, sir. Dr. Antoi, sir, introduced me to Rajkumar, sir. Sir is practicing as a consultant arthroscopy surgeon in St. George's, Bangalore. And to my surprise, he told me that he's also David Rajan sir's fellow. He did his fellowship in 1997 under DVR, sir. And he was telling me about his experience during those days. And sir was practicing in 4 hospitals. And all the teachings used to happen while traveling in the car. And he also told me that he got married during that year, 1997. And sir was kind enough to book a stay for him in Ooty for a week's time since he got married. And I also met Dr. Pradeep Kochapan during the banquet dinner. And he also told me that he is DVR sir's fellow. He did his fellowship in 2007 from Ortho 1. And he is currently practicing in Apollo Hospital, Bangalore as a consultant arthroscopic surgeon. Also told me that he is a good friend of Santosh Sahanand sir and Sham Sundar sir. And Dr. Robert Leprad was kind enough to pose with me for a photo post-conference, and also with Dr. Gilbert Moshe. So coming to the academic part, the first topic of the day was on ACL reconstruction and when to add lateral extra-articular tenodesis or ALL reconstruction. They say that both are biomechanically similar, like doing an ACL along with an ALL or an LET. But when the Kaplan fibers are injured, LET also addresses the Kaplan fibers. And when we visualize a Seagon fracture in the X-ray or an MRI, we just can open make an additional small incision and repair it with a suture anchor. That will address the anterolateral ligament also. As we all know, the other indications for ALL reconstruction or an LET would be a pivot grade 3 shift. And we also must look for other ramp lesions when there is an explosive pivot shift, and addressing that will also uh, help us to provide better biomechanical stability to the knee. And Leprad was coming up with points like lateral meniscus root tears. When there is a lateral meniscus root tear, we have to repair the lateral meniscus root, and also adding an ALL or an LET to the repair will help the healing of the lateral meniscus root and also provide better stability for the knee. And also in other conditions like where the lateral meniscus is irreparable, where we have to do a partial or a subtotal meniscectomy, those cases it is better to do an ALL or an LET, so it provides stability. Otherwise, there is some risk for graft failure because the knee is inherently stable because of the contour of the lateral compartment of the knee. And why we need to repair the lateral meniscus root, that was discussed, and it says that it prevents early osteoarthritis of the knee, and also biomechanically the knee is Lachman 2 plus or 3 when the lateral meniscus is not there. Um, and they were also highlighting about the importance of tibial drilling in corresponding to the lateral meniscus root. There is almost 40% of overlap of the ACL tibial insertion near the anterior lateral meniscus root. So whenever we are drilling the tibial tunnel, we need to be really careful. Otherwise, we may damage the anterior horn of the lateral meniscus or the anterior root. And this, as I already told, when we are not able to repair the lateral meniscus, we may need to add an LET or an ALL. And they had also spoke about, this was an article which was published, and it says that when the posterior horn of the medial meniscus root we are unable to repair, that also makes the knee unstable. So addressing the posterior horn or medial meniscus tear or the root repair also is very important, which improves the biomechanical stability of the knee. In those cases, when we are not able to do that, we may have to do an ALL or an LET. So get it right the first time. Most of the ACL injuries are not isolated. Even if we don't find any meniscal tears in the MRI, we need to probe the root and the ramp and to make sure there is no other tears, because when some isolated ramp tears or root tears are missed, there is more chances for graft failure. And always revision ACL surgeries, the outcomes are not as good as primary ACL reconstruction. So this point was brought up during the discussion. This article shows that making a single tunnel, tibial tunnel, both addressing the lateral meniscus root tear and through the same tunnel, ACL reconstruction was done. When this point was brought up, Dr. Robert Leprad says that it is not ideal to do that. The distance between the two tunnels is too far to allow for anatomic repair of the lateral meniscus. He says that a separate tunnel should be made for the lateral meniscus root tear to get it anatomically repaired. And this was another journal where they says that when we are unable to bring the lateral meniscus to its anatomic position, where we can do an all-inside repair by fixing the lateral meniscus root to the anterior fibers of the PCL. They were also not for it. They say that the consequence of non-anatomic root repair may not restore the contact pressure or contact area. As we release the subluxed root, with good release, we can bring back the lateral meniscus to its normal position and repair it. And they also did a study on the clinical outcome for medial meniscus root tear according to the age, less than 50 years and more than 50 years. Patients with not having advanced osteoarthritis or any malalignment, more than 50 years also, when we do a root repair, they do well. The failure rate was only 3 of 45, that is around 6.7%, and all of them had a clinically good outcome. There was no difference in medial versus lateral root repair. And they demonstrated and highlighted the importance of LET. Not going much into the discussion of the surgical techniques. And in case of open faces where we are doing a soft tissue graft, and with an increased posterior tibial slope or a medial meniscus deficiency, they say that it is better to do better to address the anterolateral structures also. In this study, it is shown that with BTP and hamstring tendon, when they do an ACL reconstruction without addressing the anterolateral structures, the chance of graft failure was high. That was around 17%, with PTB and hamstring 11%. When they added an ALL along with the hamstrings, it was only 4%. So coming to the importance of the slope, the posterior tibial slope, we need to always see even for primary ACL reconstruction, even though those patients with increased posterior tibial slope in uh, following the first injury, for this population, the posterior tibial slope was not as high, but there are few papers from the Middle East where they say that the posterior tibial slope being more than 12, there is more chances of graft failure. And those patients, after correcting the posterior slope and doing an ACL reconstruction, the chances of graft failure is less and the return to sports is more. So always we should look for the coronal and the sagittal alignment. But with sagittal alignment, malalignment, the chances of graft failure is less. Then coming to the revision ACLR, most of the things we are following. The only one point I felt that we follow and could be added to this slide for the fellows purpose is when we are doing a two-stage revision, and if we find any meniscal tears or meniscal tears along with the graft failure, and we are staging it, we can repair the meniscus in the first stage. And in the second stage, we can do the reconstruction. And for the meniscus root tears, what they follow is they do a two-tunnel technique. They make 2.7 mm two tunnels. They decorticate that area and do a meniscal repair. And during the demonstration, they were using fiber tapes and they were not cinching it. They say that biomechanically both single tunnel and two tunnels are similar, but biologically two tunnels seems to be better. And PCL reconstruction was also discussed. And they say that for PCL reconstruction, they always do double bundle reconstruction. Maybe the Western population, they have larger knees. And Gilbert Moshe was telling only for one case, he had done a single bundle, and that lady was only 152 centimeters tall. So there was no space for two bundle, and so they did it single bundle. They say that with the long-term outcomes, two bundle patients have less posterior sag. Comparatively, the single bundle had 4 to 5 mm of posterior sags. Double bundle had only 1 mm, and the knee was fully stable throughout the full range of motion. And they were also saying that in a PCL deficient knee, the instability is always there. It is like so they never complain of instability, but the chances of progression or to OA, the medial compartment OA and the patellofemoral OA is high. So depending upon the clinical examination and posterior sag, we will have to decide upon the PCL reconstruction. And also in chronic tears, MRI may not be that useful, and in those cases, stress X-ray gives more information. And for PCL reconstruction, double bundle reconstruction, they start early ROM with a knee ROM brace, and they put the patient on brace for a period of up to 6 months. They wean off them off the brace only by 6 months, and they do a lateral stress view X-ray at that time. Then coming to the medial knee injuries. Um Another consultant had brought up a point that most of the patients have an MCL injury, and preoperatively they have grade 2 to 3, and post ACL plus PCL reconstruction, they become grade 1 or 2, which could be managed conservatively. And for this, Dr. Lepraud's answer was it should be planned preoperatively, because while doing an ACL and PCL reconstruction, the knee joint is overstuffed and it may not open beyond 1 or 2. So we'll have to do a stress X-ray preoperatively and decide in advance whether he needs an MCL reconstruction or not. And again, the examination under anesthesia, he was telling that never hold the leg. Instead, hold the ankle, keep your fingers in the knee joint, and then open it. You can feel how much of opening is there. And if the joint is opening in full extension, the chances of the results with conservative management are not adequate, and the chances of failure is there. Then the side-to-side difference, when there is more than 9.8 mm, the complete medial structures are gone, and even after ACL and PCL reconstruction, if there is an opening, needs to be addressed. Even without an opening, we need to address the medial structures of the knee. So in chronic MCL injuries, we should always look for the alignment X-rays, and when there is a malalignment, we will have to do the distal femur osteotomy, bring it to normal alignment, and then do the MCL reconstruction. Otherwise, the chances of MCL reconstruction failure is high. And lots of patients get referred to him because of increased external rotation in the dial test and addressing as posterolateral corner injury. And most of those patients don't have posterolateral corner injury. And in chronic medial knee injuries with anteromedial rotatory instability, for those patients also, there will be dial test. So I was thinking that, so that the dial test is not for the posterolateral structures alone, for anteromedial, for posteromedial structures alone, for posteromedial structures, and also there can be a rotatory instability, and the dial test can be positive. And for chronic ACL tears or ACL with suspected posterolateral corner injury, when there is a side-to-side difference of more than 3 centimeters of the heel to bed distance, those patients more likely have a posterolateral structure injury, probably the lateral collateral ligament. And this is one of our patient posted today for surgery. He is having a ACL plus MCL injury. The posterolateral structures are normal according to the MRI, except for grade 1 sprain of the lateral collateral ligament. And in this case also, you can see how much of external rotation is there on the affected side. He has only a medial structure injury. This slide I had already explained. I am not going much into the surgical techniques and the multi-ligament, because multi-ligament injuries, most of the techniques are like as what we follow, sir. Thank you, sir.
How many people have attended?
Sir, it should be close to 400 to 500, sir.
Okay. So Moshe is also with Laprat in the same institute.
No, sir. He was with Laprat, sir, for 3 years, sir. Now he is practicing separately in Norway, sir.
Yeah, he's a Norwegian. Yeah. Okay.
Yes, sir. Yes, sir.
Must be a Jew.
Norwegian black, sir.
Yeah, and in Israel there are a lot of blacks.
Is it, sir? Oh.
Yeah, Jews are black. They could be blacks. They just fish them out from different parts of the world and brought them in. Yeah? There are some northeastern people who have gone back.
David,
I thought Israelis will be only.
David, if you go.
Yes, Gopal, you're the authority on that.
If you go back on Hebrew history, the original Hebrews were blacks. They're from Arab. That is why in Ethiopia, when they were driven from Israel, there were so many Ethiopian Jews. And there are also Jews in India. They came across the Arabian Sea from Arabia. And as you well know, the original synagogue outside of the Holy Land is in Cochin, in Fort Cochin.
Right. Yeah.
And you know, in Bombay, in 26th, which is strangely yesterday, day before, the attack happened, the synagogue that was attacked was Indian Jews mostly. So there is a small community of Indian Jews still in Bombay and also in Cochin. And
the blacks,
many blacks were Jews.
Yeah, that when I went to Israel, there was something which I didn't know earlier. You see a lot of black Jews. Jayendra,
Yes,
you said
they have
that
their own kibbutz.
Jayendra, you said the
Yes, sir.
ALL reconstruction, the tibial tunnel is very important. There should
Yes,
not
sir.
be in any confluence. But one, I think the entry point, you said something about entry point. And,
No,
you know,
sir.
we tried, tell me.
Yes, sir. Lateral meniscus root and ACL, sir. Lateral meniscus root and ACL, they use the same tunnel, sir. A few papers have come about that, sir. For that, they say that you can never do with the same tunnel because you can't get an anatomic reduction. Both are not with close proximity.
Yeah.
So,
The C-count fracture, we are not doing, isn't it? I think we must start doing that.
yes, sir. They say that only an additional incision and a suture anchor that will address the anterolateral instability, sir.
And the irreparable lateral meniscus complex, and also
Yes, sir.
another.
When a subtotal or partial meniscectomy of the lateral meniscus is done, that makes the knee inherently unstable. So those cases, we can add an LET or an ALL, sir.
Okay.
All these depends upon the demand of the patient also, I think, sir.
Right.
Yes, sir. And another point that was brought up during the conference was about the constitutional varus. How to decide about osteotomies for those patients. But it was not properly answered. What Leprat sir said was he usually puts them on a brace and see how much they improve, and accordingly he decides.
Yeah, I'm using mine. You switch off yours.
Puts them on a brace for 4 weeks and then decides.
For which condition you said?
For the constitutional varus, sir, with osteoarthritis, whether they need an HTO, how much improvement they will have, those things, sir.
Anything more about MCL? MCL sometimes to the patient keeps on coming with pain.
Yes, sir.
Was there any information about that?
Sir, about the athletes, it was discussed, sir. Those patients with MCL injury not having instability but chronic pain with maybe grade 1 opening. For those patients, he gives an HC injection, put them on ROM brace and start early ROM. They do well without surgery, sir. Yes, sir. But patients with MCL tear having opening in full extension, those patients generally require MCL surgery like augmentation or reconstruction. But it shouldn't be assessed after ACL reconstruction, sir. Preoperatively, it should be planned like taking stress views, sir.
Okay.
In multi-ligament, may not be for ACL alone. In multi-ligament, it should be planned like that, he says, sir.
So the
Jayendra,
sir?
May I ask a question?
Yes, sir, please, sir.
You know, the MCL has a superficial and a deep part.
Yes, sir. Yes, sir.
When the medial aspect is opening up in extension, that means the deep part is torn, which means the superficial is already torn. You cannot tear the deep medial collateral without stretching or tearing the MCL. But if the knee is unstable in flexion, it doesn't necessarily mean that the deep MCL is torn. So that is an examination that we must do in a knee injury.
Yes, sir.
And also, there is no need to run and jump and repair the lateral complex when you have so many other things to take care of. Especially these patients come with multiple injuries and comorbid conditions, upper extremity fractures or contralateral, what have you. You can safely brace them, bring them back and repair the lateral complex.
Definitely, sir. Definitely, sir. Up to 3 weeks of waiting is doesn't make anything worse, sir.
Very nice paper, and I enjoyed it. It was very thought-provoking.
Thank you, sir. Thank you, sir.
No, you went to Jaipur to attend a congress, Gopal, for which Laprade and Moshe had come. He had come.
Yes, wonderful, wonderful. And I think the fellows who are from Kerala, അവര് അവിടെ കൊച്ചിയിൽ വന്നിട്ട് അവിടെ സിനഗോഗ് കണ്ടിട്ട് ജൂതന്മാരെ കാണണം കേട്ടോ. I'm talking to the Keralites.
Santosh there? Let's start. Jayendra, you have to mute
the
your.
next one.
Yes.
Jayendra, mute your.
One second, sir.
Good morning, sir. Is my screen visible, sir?
Yes, go ahead, please.
Thank you, sir. Today I'll be discussing on the evaluation of glenoid bone loss, mainly the erosion type. So, first I'll be discussing the different things I'll be discussing will be on the different mechanisms of glenoid bone loss, the glenoid bone loss assessment techniques, and how it helps in decision making. So first of all, while patient encounters an anterior dislocation of the shoulder, the different mechanisms by which glenoid bone loss can happen is first is the fracture of the avulsion fracture of the glenoid rim along with the labrum. That is one. The second type is avulsion, where the labrum actually detaches from the bony part, and the third one is the erosion type, which happens over a longer period of time when the humeral head actually rubs on the glenoid rim, and the erosion happens over a period of time, and it is again classified by Biglani into type 3A, which is less than 25%, and B, which is more than 25%. The other type of bone loss is the attritional type of bone loss. It is to be differentiated from glenoid bone loss erosion, in the sense that in attrition, the attrition happens in the free bone fragment. The initial fractured bone fragment over a period of time, it gets absorbed by the body and then it undergoes attrition. That is called attritional bone loss, which has to be differentiated from erosion. So in this picture, we can see in the figure A, there is glenoid bone loss percentage assessment, where we put a perfect circle on the lower part of the glenoid, and the part of the bone loss, that is X, is divided by the total surface area of the perfect circle and is multiplied into 100 just to find out the percentage of glenoid bone loss. Whereas in attritional bone loss, what we do is we find out the size of the remaining fragment, which is Z, using a software. From the end-phase 3D sagittal view, we find out the surface area of the remaining bony fragment that is inside the body. Then we divide it by the surface area of the actual bone loss from the glenoid, that is X. Then we subtract it from 1. The ratio we subtract it from 1. That is how we get the attritional bone loss. So this has to be differentiated, the different mechanisms of bone loss. And then this is another classification based on the attritional bone loss, which is classified again as less than 34% is type 1, 34 to 67% is type 2, more than 67% is type 3. And this is again a picture showing in a 3D sagittal view the difference between erosion type as well as the attritional type. In erosion type, in the figure A, you can see that there is it's sort of a compression type of fracture on the cancellous bone, and the margins appears to be more smoother. So that has happened over a chronic period of time. By the rubbing of the glenoid by the humeral head, the glenoid erosion has happened. And in figure B, we can see that the margins are fairly sharper. So that has happened from an acute fracture. The loss of bone fragment is acute, and then the lost fragment then undergoes attrition over a period of time. So this has to be differentiated. But coming to the incidence of bone loss, whatever is the reason for bone loss, if there is a bone loss, significant bone loss in the anterior inferior part, it results in instability. So how much percentage of patients will have bone loss? Glenoid bone loss, isolated glenoid bone loss occurs in at least 50 to 95% of cases in recurrent glenohumeral instability. And isolated humeral head bone loss occurs in about 93%. But we have to always club these together and see the resultant effect of these happening together. That's called the bipolar bone loss. That happens in around 62% of patients. So we should never look at bone loss as glenoid alone and Hill-Sachs alone. It should be combined together, and then only it will help in deciding the management. Next, coming to the quantification of bone loss. So I'll be discussing about the quantification of bone loss in the glenoid, and the different modalities used are X-ray, CT, MRI, and arthroscopy. X-rays basically, the problem is they do not help us in quantifying the bone loss. They will just help us in identifying if anterior inferior bone loss is present or not. And their use is mainly after once a dislocation happens and once we reduce it, we take routine views to make sure that the bone is reduced. So that will tell us if the bone is reduced, but it will mostly, sometimes it will hide the bone loss if it's present. So we take some special views, which are the West Point view, apical oblique gap view, and the Bernaghi view, which tell us if glenoid bone loss is present or not. But keep in mind that this doesn't help us in quantifying the bone loss. That is a limitation. So this is the West Point view, and this is the apical oblique gap view. This is the Bernaghi view. I won't be discussing these in detail. The one which helps us is the CT, which helps us in quantifying the bone loss, which helps us in making decision making process. So the first one is again showing an acute fracture of bone loss from the glenoid. Second one is showing a glenoid erosion over a period of time. You can make out the difference from the CT. So when should we do a CT? Once we get a dislocation patient, if there is a if the reduction X-ray or special views are showing glenoid bone loss, or if the MRI is showing an evidence of bone loss, we should get a CT done. Or if there is a high energy trauma history, multiple dislocation history, or in failed isolated stabilization procedures like a failed Bungard procedure, or a dislocation after trivial trauma, or even with little provocation like dislocation that happens during sleeping. So if a patient comes and says that I'm getting the shoulder dislocated during my sleep, that is an indication of significant bone loss, and CT has to be done. Then instability in mid ranges of motion, that is from 20 to 60 degrees of motion. If the patient is having instability, that again suggests a significant bone loss, and CT has to be done. Then inferior instability and any history of difficulty in reduction. So these are the indications when we need to get a CT done. So coming to different methods of quantifying bone loss, there are so many methods described in literature using a CT to quantify bone loss. I'll be discussing the main methods, the most commonly used methods. The first is the best fit circle, or the perfect circle method, or the Sugaya method, wherein we get the 3D reconstruction image of the sagittal view of the glenoid in face. Then what we do is we draw a vertical line from the supraglenoid tubercle from the supraglenoid tubercle to the infraglenoid tubercle, we draw a vertical line. Then we put a point on the lower one-third, upper two-third junction on the lower part. Ideally, the lower part of the glenoid in face should appear pear-shaped. The glenoid should appear pear-shaped with the lower part making a circle. So we put a point on the middle of that circle in the lower third, and then draw a circle based on that point. Then we measure the whole diameter of that circle. That is the line, that is the length A, which has been mentioned here, the length A. We measure the whole diameter. Then from the anterior rim of the glenoid, we measure the distance till the end of this anterior end of that circle. So that is the small measurement B. So then we divide this B by A into 100. That gives us the bone loss measurement. This is a linear measurement method. I'll come to the classification later. This is a linear. We are not measuring the surface area. We are measuring based on the linear measurements that we take. This is the Sugaya method. Next is the PICOS method. This is a surface area method wherein but the problem is we have to take a CT of the opposite normal shoulder. So it has some additional radiation exposure. And in this method, we put on the lower third of the glenoid, we draw a perfect circle, and surface area of that best fit circle is calculated. Then the same circle is again put on the affected side. And then the surface area of the bony glenoid within the circle is calculated. Then A minus B by A, the total actual surface area. This is the formula. Then the surface area the bone loss can be calculated in percentage. Next method is the glenoid index. This also uses the opposite normal glenoid CT. So again, a normal glenoid, we draw a circle, the same. The diameter is taken. The diameter of the normal affected glenoid is taken. The ratio is taken, and the bone loss percentage can be taken up. This is again a linear measurement method. Next is again another surface area method. This uses the software wherein we draw a circle again on the lower third of glenoid. we calculate the surface area using software for the fractured glenoid piece. Then we divide this surface area by the actual surface area. But the problem with this method is if there is attritional bone loss of this glenoid fragment, then the bone loss will be, the estimated would be lesser. So it cannot be relied upon in chronic cases because, as I told earlier, this bone piece that is fractured may undergo attritional bone loss, and over a period of time that may not actually represent the glenoid bone loss. So not a reliable method. Next is the D-Filippo method. This is again using MPR, multiplanar reconstruction methods in CT. Again, software based. We draw a line around the margins of the glenoid, calculate the area of the normal side, then again draw margins along the affected glenoid, then calculate the surface area of this one. Based on comparing these two, again you can get the surface bone loss area. This is MPR based, so software based. Then coming to arthroscopy. So how do we assess bone loss in arthroscopy? What we do is once we do a arthroscopy, we find the bare spot in the center of the glenoid, and then we take a measurement from the bare area to the posterior part, remove the glenoid, and we measure again from the bare area to the anterior rim of the fractured glenoid. So then the ratio is BC minus AB, the length difference we take on either side, the length BC minus AB by 2 times BC, the actual diameter of the glenoid, into 100%. But this arthroscopic method also has a problem. The problem is we identify the center of the glenoid using the bare spot, the part where there is no cartilage. So that part, that bare area is not always in the center for majority of the population. We consider it to be in the center of the glenoid, but in majority of the population that happens to be around 1.4 mm in the towards the anterior rim of the glenoid. So since it is towards the anterior rim of the glenoid, it can tend to overestimate the bone loss. So how do we measure bone loss then? So these are the two systematic reviews which came out recently assessing the different methods of quantification of bone loss in anterior inferior instability. So this is recently published as 2021. So what they have stated is, the conclusion is there is no gold standard method. All methods have some flaws. There is no gold standard method because even in CT end phase view, once we take the end phase view, even if there is a 5-degree tilt to the end phase view, there is a difference in glenoid bone loss measurement. So intra-observer and inter-observer reliability is not good for any of the methods, not 100% good. There is no gold standard. Then which method can be used? Among the methods that is provided based on CT, the surface area methods tend to be better when compared to linear measurements. And those which have used the opposite shoulder normal glenoid measurement also tends to give a better approximation to the glenoid bone loss than the one with only the affected side. But that there is also a side effect to that we have to take a normal side CT, and that has more expenditure as well as radiation exposure. Then the latest technology was using MRI, but the problem with MRI is reliable assessment using an MRI will be got only if there is a 3D reconstruction MRI. 3D reconstruction MRI is not available in most places and is very costly. So using 2D MRI, the bone loss assessment was found to be inferior when compared to the 3D CT. So 3D images are always better, and 3D CT was found to be better than the 2D MRI. 3D MRI is costly and not available in most centers also. So which method to use finally? The easiest method to use is the Sugaya linear measurement method. And the Sugaya method is the easiest one. With the only one shoulder CT, we can easily measure it. More reliable method would be a Pico surface area method. Then coming to categories of glenoid bone loss. So the traditionally in 2000, Itoi et al. As well as Burkhardt and DBR et al. In different papers have categorized glenoid bone loss as mild less than 15, moderate 15 to 25, severe is greater than 25. So this critical bone loss essentially means whenever there is more than that much percentage of bone loss, critical bone loss, when we do an isolated soft tissue procedure like Bangad, the chances of it failing is very high. That is the meaning of critical bone loss or significant bone loss. So traditionally, previously it was considered to be 21 to 25%. But recent literature, these are the recent studies as as late as 2020 has shown that the critical bone loss values are actually in the recent literature has been coming down. Even the current literature says that from 20% it has been brought down to 13.5%, when we should consider that isolated soft tissue procedure like isolated Bengard repair may result in a failure. So it even if not resulting in a failure, the functional score outcomes have shown to be reduced when the critical bone loss is kept at 20%. So newer studies have brought the limit down to up to 13.5%. And this is again another study redefining of critical bone loss, which says that it has to be brought down to 13.5% since it has shown an improvement in functional outcome scores. Next, even in recent literatures in 2021 has shown that in athletes, in high activity individuals and in young individuals less than 23 years of age, even the limit has been brought down to around 10%. But this has to be taken with a pinch of salt, and more studies has to be brought. The limit has to be brought out till 10%. The limit currently has been the limit that we follow right now in literature is 13.5%. Now we'll be talking on what is the importance of this glenoid bone loss. So the glenoid on track, off track, engaging, non-engaging lesion has been discussed previously. So I'll be discussing how to calculate it using the glenoid bone loss that we have calculated. Usually the glenoid track, as we know, is the track that the humeral follows on the glenoid end face surface, the track that it follows. So usually it follows 83% of the width of the glenoid. Usually the glenoid track, the humeral head follows on 83% of the width of the normal glenoid. So what we do is we calculate this 83% of the width of glenoid and then draw the same diameter onto the humeral head. And from where do we draw it? This R is the rotator cuff insertion, just middle to the GT. So the rotator cuff insertion, from that point, we draw the glenoid track. That is the same length that is measured 83% of the glenoid. So then we find the heel sac lesion. This is the heel sac lesion. So then next step is, we have normally if the glenoid is intact, then diameter is the capital D. If the glenoid is not having any bone loss, the capital D is the diameter. Suppose the glenoid, as in the cases that come to us, the glenoid will have some bone loss. That is the small d. This is the bone loss measurement. From the maximum width, we take the maximum width of the glenoid, so the horizontal width, and then we calculate the bone loss length measurement. So then what we do is, usually in a person, I told you 83% is the glenoid track. So if there is a bone loss of small d, length of small d, we have to reduce that from the glenoid track to get the actual glenoid track in a person with glenoid bone loss. I hope you understood this. So 83% is the actual glenoid track. If there is a bone loss of small d from the glenoid, we have to reduce that amount also, that small d also, from the actual 83% to get the actual glenoid track. So then that is a white arrow. That is measured in the white arrow. So then we again trace it from the rotator cuff insertion. The small white arrow is the actual glenoid track in a person with bone loss. So we can see that previously non-engaging heel sac also can become a engaging heel sac when we trace the actual glenoid track, which is reduced after the bone loss. So again, you can see in this one, 83 to 84% is the actual glenoid track. When there is bone loss, that glenoid track also has reduced. So a previously non-engaging heel sac has become an engaging heel sac. Next, coming to again the final definitions I told. This is the rotator cuff insertion. The distance from the rotator cuff insertion to the heel sac lesion is known as the cuff heel sac distance, CS. So this I marked here as in red ink. Distance from the rotator cuff to the heel lesion, that is heel sac distance. Then heel sac width. The green line is the heel sac width. That is the maximum width of lesion. Combining these three, we get the HSI. That's the heel sac index. This is what we have to calculate. The heel sac index is what we have to calculate. So when we calculate the cuff heel sac distance, heel sac width, and combining those two, we get the heel sac index. So if the heel sac index, when we are calculating, is less than the glenoid track, then there is no problem. The whole hill sac is inside the glenoid tract. It is a on-track lesion or non-engaging lesion. If the hill sac index is more than the glenoid tract, that means the distance from here to here, it is overlapping the glenoid tract, it becomes an engaging lesion. That is a basic fact. That is a basic fundamental fact. So the problem with this is, in recent studies, this was published in December of 2022. In most recent studies, what they say is, the downside to this is a binary calculation. This is either engaging or non-engaging. It's like, even if the hill sac index is coming up till the glenoid tract around 1 mm from here also, that is an on-track lesion. It is considered safe. So it's a binary concept. So the newer concept is, we have introduced a new term called distance to dislocation, DTD, and near track hill sac lesion. So what that means is, the on-track lesion, distance hill sac is easy to understand. I've already told you hill sac index. Hill sac index is from the rotator cuff insertion to the medial margin of the hill sac lesion. So that's the total length is called as the hill sac index. And glenoid tract is the one that we measure. 83% of the remaining glenoid we put over here. This is the arrow that is shown here. That's the glenoid tract. So on track means it is just behind the glenoid tract. So from here, this is on track. The on track I'm showing with my arrow here, this column, this is the on track. That means it is just behind the glenoid tract. It is just within the glenoid tract. So it is engaging. It is non-engaging, on-track lesion. If it crosses it, that is off-track lesion, it will engage. So instability. So what about the near track hill sacs? So distance to dislocate is GT, glenoid tract minus hill sac index. So the total glenoid tract minus the hill sac index till here. So if that is even just more than 0.1 also, or even 1 mm also, that is a on-track lesion, considered to be a safe lesion previously. But the new terminology says that in near-track hill sacs, if the distance to dislocate from 15 mm, once it reduces down to 10 mm, and once it comes less than 10 mm, there is a chance of failure of surgical procedures. So that is considered near-track hill sac lesion, and even those are considered to be not a benign lesion and has to be addressed. So this is how we calculate. DTD is equal to GT minus HSI, that I've explained the terminology. So off track is when it is less than 0, on track is if it is even less than 0.0 also, 0.1 also. Near track is when it is less between 0 and 10 mm, and that has to be considered to be significant. That is a newer concept. And then the one more study that was published in 2021 was comparing the same distance to dislocation as an independent risk factor for failure, that is independent of bone loss and hill sac index. And it showed that once the distance to dislocate came to less than 10, so this is distance to dislocate plotted against the probability of failure. So it is 30, everything is fine. 20 also, the dislocation rates are very low. Once it comes less than 10, as shown here also, 10 mm, then probability of failure is 29. 8 mm, 36. 6 mm, it becomes 46. So what they say is, once the distance to dislocate values come down, we have to consider that as a separate independent risk factor and has to be addressed. So even near track lesions also has to be addressed. Next, I've already told that glenoid bone loss in isolation cannot be considered as a risk factor for considered as a factor for deciding management of the principal. This is the flow chart that I made. So if it's less than 10% without no or non-engaging hill sac lesion, Bengard, this is the, I just showed this chart to say that it is not an isolated glenoid bone loss that has to be taken into account. Also, the humeral bone loss, as well as whether it is engaging or non-engaging, also has to be taken into account. And the various treatment methods along with the treatment protocol is going to be discussed by Dr. Rohit in the next presentation. I just put up this final slide so that you'll understand that the only isolated glenoid bone loss doesn't make sense in making a decision. So coming to take-home message, I just want to stress upon the types of glenoid bone loss. It could be an acute fracture, it could be an erosion over a period of time, or it could be an attritional bone loss. And always consider bipolar bone loss, not just glenoid, not just humeral bone loss. Combine it and then come to decision management. And there is no gold standard for measuring a glenoid bone loss. And the near track lesions, which is a newer concept, has to be considered when we are considering isolated Bangat repair. Thank you, sir.
Thanks, Govind. Now, does this tracking play important role in glenoid bone loss more than 13 or more than 14% at present?
Yes, sir. When we combine it with the humeral bone loss also, even if the smaller amount of glenoid bone loss also becomes engaging, since if we consider it as a near track lesion, it also can become engaging, sir. So the critical limit has been reduced.
Yeah. So maybe if you happen to attend our CME after 5 years, you may find that a 5% bone loss is also considered as an extremely critical bone loss. This concept keeps on evolving, but we cannot follow exactly the Western methodology, because they try to improvise on the measurement methods and then their follow-up study, and then they suddenly come up with a new finding saying that you cannot restrict Letarge to only contact sports. You have to do it for a normal population also. There may be a chance for coming out with this result in future. But keep in mind, our Indian population is totally different. What
Okay,
they
sir.
expect, one surgery, everything should be fine. So you have to be very wise in choosing the procedure of choice. And that's the reason why in Ortho-1 we had been following this concept of using a bone block procedure for patients who are high demand athletes or manual laborers or military personnel ever since 2014. And we have been quite successful in finding that our recurrence rate in dislocation is very less. It's probably 1 or 2% or even lesser than that. Literature says the redislocation rate following Letarge is 5%, whereas in our case series it's very less, and which means our decision making, or no, the foundation of what we understood with respect to instability is good enough. And the only thing is this concept keeps on evolving, so which means we should not keep changing our protocol. Our protocol holds on good, and the Ortho-1 protocol is as good as or on par with the international standards.
Okay, sir.
Yeah, so it's very important to know the profile of the patient and what kind of character he is. Now, some of them say, I don't do this, that, and all that, but they may go back and do things they are not supposed to be doing and rip it off. So you have to ask a few questions before deciding on Bankat repair alone. Very important. Profile of the patient. Your flow chart is very good, except for the profile of the patient. Thank you.
Am I audible, sir?
Yes, Rohit.
Yeah. So I'll be presenting on the current concepts in management of anterior inferior shoulder instability today. Before we go into that, let's just have a look at what Govind talked about a little. So when you come across instability, you will divide it into a glenoid bone instability and a humeral bone instability. Along with that, if it has both the components, it's called the bipolar instability. So like Shyam sir mentioned right now, looking at the Indian population, we keep somewhere between 20 to 25% rather than having a critical or a subcritical bone loss. So if the functional demands are low and it's less than 15%, we would just go in for an arthroscopic Bankats. If the functional demands are high, score is bone loss is more than 15%, then we would think of some bony open procedures like a Letarge or a bony block or something. Coming to the humeral side, when the lesion is less than 20%, we think of doing nothing. 20 to 40% is the time when we would go in for a remplissage or a open fixation, and more than 40 we would need to put in an allograft. The same thing when you combine together, you will have to treat the bipolar lesions in a similar way. So what is Bankard's repair basically? Bankard's repair is Bankard's lesion is nothing but the anterior inferior rim of the glenoid that comes off along with the labrum. So if it comes off with the bone, it's called as a bony Bankard. If it comes off just the labrum, it's a Bankard's lesion. So Guiti studied this paper in 29 shoulders. He had a mean follow-up 6.7 years. He showed that the pre-row scores were 49.1 plus or minus 7.8 and post-row scores were 92.1 plus or minus 6.4, which was significantly better. He thus showed that glenoid defect less than 20% and arthroscopic Bankard's repair with the remplissage provided better outcomes. So how do you increase your outcomes, or how do you get a good Bankard repair? You have to do a thorough diagnostic first. Along with that, your portal placement has to be perfect and spot on to assess that 530 position. Along with that, you have to make sure that there's an inferior capsular shift that is created, and you have to have a good bumper effect. And the more number of anchors that you put in, apart from the monetary component from the pharma companies, will provide less strain on the already existing anchors, or the less number of anchors that you put in. So this is a small video demonstrating how the technique is done.
Step in the procedure is to use an elevator to mobilize the soft tissues from the front of the glenoid. The labrum is typically scarred down, often in a medial position. It is important to mobilize this soft tissue and free it up from the glenoid so it can be placed back up onto the face of the glenoid in an anatomic position. Operation can be visualized from the anterior cannula. Next, we will bring in a rasp to stimulate a healing response. A drill guide is placed on the face of the glenoid inferior as possible, in this case at the 530 position. We then drill and tap the anchor into place. It is important that the anchor is placed onto the face of the glenoid. We'll use a suture passer to grab capsule inferiorly and pass it up underneath the labrum. A number 1 PDS is used as a suture shuttle. It is pulled out of our anterior superior cannula, loaded with the suture, and passed back through our anterior inferior cannula. The knot is positioned appropriately to ensure that the soft tissues are shifted superiorly. We use a sliding locking knot followed by half hitches. The sutures are then cut. And finally, our goal is to utilize a minimum of 4 to 6 anchors to ensure a solid repair and to decrease the risk of recurrent injury.
Next, coming to remplissage. Remplissage is a word which basically means to fill the defect. Now, when you have a Hill-Sachs lesion, Hill-Sachs happens on the superior posterior aspect of the humeral head. So that, like Govind explained, the on-track, off-track, and the engaging, non-engaging lesion causes a pivoting between the two, which tends to dislocate the humeral head out. Hewley did a study in reviewed 740 patients where he compared arthroscopic Bankards and remplissage and arthroscopic Bankards alone or Latage. He found significant differences in recurrent rates between the arthroscopic Bankards plus remplissage and arthroscopic Bankards alone, 3.2% versus 16.8%, which was significant. There was no significant difference in recurrence rate between arthroscopic Bankards plus remplissage and Latage. That's 9.8 versus 7%. Significant lower complication rates, though, were observed between just arthroscopic Bankards repair and remplissage compared to Latage. So this is just what it is. This is the Hill-Sachs defect.
And then punch.
This is where the Hill-Sachs anchor is placed. These are the bites that are taken.
Then come back to the subacromial.
And the infraspinatus muscle is filled and filled inside and packed.
And after I've reduced.
Malvato did a study in 41 shoulders with a mean follow-up of 2 years, where he looked into scores at preoperative, immediate post-operative, 6 months, 12 months, and 24 months. He's assessed and he found significant improvement in scores with a bony procedure like a Latage compared to just a soft tissue procedure. And he concluded that combining a bony procedure would have a better outcome compared to just a soft tissue procedure. This is a newer modality that has been used. It's called the Glenoid. Glenoid is nothing but an allograft. Allograft, instead of taking your coracoid or any other bone substitute, and that is placed into the glenoid defect. This is just a small video showing how to prepare the Glenoid.
Start by tying a suture knot over a small thin object such as a freer. Once this is secure, remove the freer. Trim the tails of the knot short. As you can see, the graft has 2 large holes for later screw placement and 3 small holes to capture suture for capsule repair. The side of the graft that will abut the glenoid is flat, and the other side, which will later repair to the capsule, is convex. Thread another suture through the loop you previously created so that the tails are even. Then thread the 2 tails of this suture through the flat side of one of the small holes in the graft. Pull this suture all the way through, including the loop of the prior suture. The knot of the loop will prevent the entire construct from pulling through.
The same thing is done for the other 2 holes. Coming to arthroscopic form of a Latage, Castrichini did a study where he assessed the complication rates for arthro Latage, and he found out there was just 3% chance of a coracoid rupture, 2% chance of screw intolerance, and nothing more. In the first picture, you can see clearly that the subscapularis is split using the double cannula. The second picture, you can see the bone block being placed with the screw, and here you can see both the screws and the wire coming out. This is a small video to demonstrate arthro-Latage.
1. Limit coin osteotomy and bone block preparation. A 25 millimeter incision is taken. The ground floor process, the A ligament, pec major, and conchae tendon are identified and measured. The pec major is separated. Then the groin is cut along the designed line by an oscillating saw with conchae tendon and the CA ligament intact. The groin is overturned, and the conchae tendon is then mobilized for 5 centimeters with index finger. A 2.5 millimeter central tunnel and a 1.5 millimeter side tunnel are drilled perpendicularly on the coracoid. 3 high-strength sutures are pulled through an end button and the central tunnel for fixation, while another suture is pulled through the side hole of the end button and the side tunnel for anti-rotation of the graft. All the preset sutures are placed into the cannula and inserted into the incision just anterior to the subscapularis. Then the incision is closed. Step 2. Glenoid preparation and bone tunnel drilling. Regular posterior and anterior lateral portal are made. The midpoint of the anterior glenoid edge is marked for anti-rotation anchor placement. The barrier in its anterior glenoid is marked for tunnel drilling. The rotator interval tissue is removed until the anterior placed graft can be visualized. The anterior inferior glenoid is freshened and smooth for bone graft fitting. From the posterior portal, a custom-made locator for tunnel drilling is set under guidance of a Swiss stick. A K-wire is drilled in and followed by 4.5 millimeter end button drill. A PDF suture is seated as the guide suture for graft pulling in. Step 3. Mini window split of subscapularis. The subscapulary is split from posterior to anterior half a clock lower than the bone tunnel. Once the anterior cerebellum of the subscapularis is visualized, A Swiss stick is introduced from anterior portal into the speed window and placed on the glenoid surface to protect the axillary nerve. Step 4. Bone block transfer and fixation. The PDS suture is pulled out by the grasper through cannula and speed window. Under guidance of the PDS suture, the preset fixation sutures are pulled posteriorly through the glenoid bone tunnel. Then, a grasper is inserted posteriorly through the speed to pull the anti-rotation suture backward outside the posterior portal. By pulling the two sets of the sutures, the bone block can easily be pulled backward through the subscapularis speed inside the joint and placed. Then another end button is tied with the fixation sutures in the posterior side. And finally, by using the grasper, the graft was adjusted until it fits the morphology of the glenoid and fixed by anti-rotation suture with push-lock anchor at the designed position.
So this can be fixed with screws with endo buttons. Coming to this study done by Takashi, where he looked into 44 shoulders. He studied for a minimum of 30 months. He found out there was a significant improvement in row scores pre-operative and post-operatively, and UCLA scores pre-operatively and post-operatively. He stated that combined arthroscopic Bancards with an open Bristow or a Latarjet improved bone morphology, which this was a reliable method in treating collision or contact athletes. Coming to QT-SO, QT-SO is nothing but a modification technique. In Bristow, what we do is we take that coracoid and we place it perpendicularly on the glenoid defect. In Latarjet, we place it horizontally on the glenoid defect. In QT-SO, a tunnel is made on the glenoid defect, and this block is pushed in horizontally. It's like an inlay type of technique. This goes inside. This provides better bone-to-bone contact, thus improves, decreases non-union rates and improves union rates. Adenabony. Adenabony is when there is a significant bone loss, or you have a Latarjet or a QT-SO or a Bristow failure. Then you want to place in another bone. So what normally they do is they take the iliac crest tricortical graft. This is modified and cut into the desired shape and length and placed in the same manner as your this would be Latarjet would be. So Amadis did a study on 28 patients where he looked into glenoid bone loss of 12.4% with a 3 years follow-up, and he showed that there was a significant improvement with the Adenabony procedure. This is how the spine graft technique that Shamsa was talking about. This is what it is done. I'll show a small demonstration of the video.
Posteriorly flush on the glenoid.
The spine of the scapula is basically used as a block and placed anteriorly. They're placing the drills, making holes in the glenoid.
To shuttle two fiber links of different color. After shuttling the fiber links, precise measurements from the drill hole positions are taken. For better illustration of the harvesting of the scapular spine bone graft, we move to the anatomy lab. If we take a look underneath the skin, we can see the scapular spine. The bone graft is going to be harvested 5 centimeters laterally from the medial border of the scapula. After performing a skin incision of about 5 centimeters, the scapular spine is freed from soft tissue. Superiorly, you will find the attachment of the middle trapezius, and inferiorly, the attachment of the deltoid muscle. A color pen can be used to mark the extent of the harvest site. And we can see that the typical graft that you can harvest is sufficiently large in order to reconstruct the anterior glenoid rim. The harvesting can be performed with small saw blades. First, 2 perpendicular cuts are made with a straight saw, and then angled saw is used to make a transversal cut. This then allows
to harvest the bone graft. Once the graft is harvested, the harvesting site can be filled with a hemostatic sponge before closure of the fascia graft, as just shown in the anatomy lab. The inferior fiber link was used to shuttle 2 fiber tape bone cerclages through the glenoid and through a drill hole made on the graft.
Now they're going to pass the graft through
of the
under
fiber
vision
tape cerclages through the inferior hole in the graft. The cerclages are passed back via the superior hole of the graft. Now the superior fiber link is used to shuttle the cerclages. Digital palpation is performed. Graft is
This is how they push it in.
with the use of a clamp, and at the same time, the interconnected bone cerclage rim.
Finally, it'll look like this.
Alternate the use of a tension device.
And sits snugly on the glenoid defect. Coming to the DAS procedure, Clara Esbiedo did a study where she looked into 15 patients with a mean follow-up for 1 year. She limited her study to subcritical bone loss, that's less than 20%. She showed an improvement in significant row scores, a difference in row scores, and recommended that this procedure for anterior instability for less than 20% of glenoid bone loss. This is a small video for that.
Suture is introduced through the anterior portal underneath the biceps. A perforating suture grasper pierces the tendon,
This is the biceps
grabs
tendon.
the suture, and creates a loop.
Loop is created around the
Both
biceps
suture
tendon.
strands are pulled through the loop, one posterior and the other anterior to the biceps. Like this, a 360 degrees bretzel-like loop is created into and around the biceps.
Proximal tenotomy will be done now.
The long head of the biceps tendon is released from its intertubercular tunnel by cutting the posterior pulley and the transverse ligament using the radiofrequency ablation probe facing the lateral crista femori through the D portal. The subscapularis split is performed by advancing the switching stick from posterior to anterior, parallel to the glenoid surface. The previous suture ends are retrieved outside the A portal after pulling them through the subscapularis split. The trans-subscapular transfer of the long head of the biceps tendon is performed by pushing the tendon with a tissue grasper from the E portal, while simultaneously gentle pulling both suture limbs from the A portal. Once the biceps is observed intra-articularly, its suture limbs are passed over the superior subscapularis margin and then retrieved outside the E portal for preparing the tenodesis using a 3.5 millimeter knotless anchor. Final verification from D portal. The sling effect of the transferred biceps.
Coming to the Chillat procedure. Chillat procedure is a very straightforward procedure. Pascal Boli demonstrated and stated its one clear indication that a recurrent shoulder dislocation, which is associated with a functionally irreparable cuff tear, is an ideal candidate for this type of procedure. So Labot did a study in 18 patients with a mean follow-up of 24 months. He showed there was a significant improvement in knee scores, and this, he stated, was a better and simpler procedure which was reproducible than the arthroscopic Latarjet. This is exactly what a Chillat is.
The section is only made medially as far as the medial border of the coracoid.
The coracoid is basically cut under
surface. It is bent over the conjoint tendon is identified.
It can be fixed or it can be left in the same way.
Next, the superior surface of the coracoid process is debrided. Here you can see the anterior portion of the conjoint tendon and the pectoralis minor tendon, which has not been detached. A motorized rasp is introduced via the northwest portal.
The base of the coracoid.
The osteotomy is made at the base of the coracoid process. We advocate the use of a combination of the rasp and a motorized burr to perform the osteotomy. Once the osteotomy is completed, the coracoid process drill guide is introduced via the north portal and positioned over the tip of the coracoid process. The hole is drilled under direct vision and the central drill is removed, leaving the outer drill cannula in situ. A PDS shuttle suture is used to pass the bone-linked sutures through the coracoid process. The button is seated against the superior cortex. The sutures are then managed by placing them in the north portal. The glenoid drill guide is introduced via the half pipe and the tip placed at the desired exit point on the anterior glenoid surface. The half pipe is removed and the glenoid tunnel is drilled. A switching stick is used via the west portal to retract the subscapularis muscle whilst drilling. The drill guide is removed and the drill cannula left in situ to allow passing of a PDS shuttle suture, which is retrieved via the west portal along with the bone-linked sutures. The bone-linked sutures are then passed through the glenoid tunnel once the drill cannula is removed, and these are retrieved posteriorly.
This is through the glenoid. And now they'll pull these posteriorly, and the osteotomized coracoid will go sit flush on the glenoid effect.
The second button is then loaded over the sutures, then the two loops are separated and a knee snot is made. The button is cinched to the posterior glenoid without tension. With the button tensioner device loaded and the arthroscope placed in the posterior portal, the bone link is progressively tensioned under direct vision. Here, the coracoid process can be seen being transferred inframedially. The degree of coracoid transfer is assessed progressively throughout tensioning, whilst the arm is rotated, assessing for subscapularis excursion. Once the coracoid transfer is completed, we can see the sling effect created by the conjoint tendon.
So coming to our preferred treatment, if it is something like a subclinical bone loss, a bony erosion, or a bone loss less than 20%, we would go in for a soft tissue reconstruction in the form of a Bankart's and a remplissage. If it is more than that, we would supplement that with a bony procedure like a Latage. If there's a defect or if there's a recurrence, a failure of that, we would go in for a bone block procedure like the scapular spine or the head in Hebene. After surgery, we would keep the patient immobilized in an abduction pillow for the first 1 month. We'll start elbow and wrist ROM. After 1 month, we would slowly get up to shoulder level at passive ranges and start with passive ROM exercises of the shoulder. And the next month, that is the second and the third month, we will start with overhead and strengthening. From 4 to 6 months, we will emphasize and improve strengthening exercises. Post 6 months, the patient can go on to his normal daily activities. Conclusion: correctly identify the nature of the dislocation and the need for an appropriate surgical intervention. Classify glenoid and humeral bone loss and pre-plan the surgery depending on the percentage of bone losses and the patient's profile, which is most important. Newer surgical techniques have a longer learning curve. When required, always complement a soft tissue procedure with a bony procedure. Thank you.
Very well said, Rohit. The indications for a Trilat procedure is very small, very small percentage of population. Young patients with a cuff tear with an instability. So the newer concepts like the dynamic anterior stabilization is you should not mistake it for a replacement for a Bankart repair. It is not a replacement for a Bankart repair. Dynamic anterior stabilization is an adjuvant, which means you do a Bankart repair, and if you feel that the quality of the tissue is bad, that it may not be strong enough to withhold the anterior translation, then DAS is added as a supplement. But dynamic anterior stabilization alone will not prevent dislocation. So we have to be very careful in understanding the concept. And it is still not clearly understood whether the dynamic anterior stabilization, that is the longered biceps, has got the resting tension to replicate the same which is being reproduced by the conjoint tendon in case of a Latage. All right. So because you remove the longered biceps and then just refixed, you removed from the supraglenoid tubercle and then refixed on the glenoid, which means it is still lax. So whether you take it into abduction, external rotation, whether it really retensions the inferior aspect of the subscap, we don't know. So that's the reason why the experts are advising that it can only be used as an adjuvant, and it should not replace the concepts of a Bankart repair or even a Latarjet. Doing an arthroscopic Latarjet has got its own pros and cons. I have not done any arthroscopic Latarjet, but whatever I've heard from the experts is that time consuming. Second thing is each and every step is very important, and the very high chances of not preparing the graft, the glenoid graft properly, which means you need to rasp the undersurface in a correct manner and try to fix it the right way. If any step goes wrong, then it's a disaster waiting to happen. So if I'm comfortable doing an open Latarjet and my post-op CT looks beautiful, then I might very well stick on to the same principle, which has been successful for past 10 years. So I wouldn't actually venture into arthroscopic Latarjet, except for the fact that that's one checklist which needs to be ticked. That's all. But I'm not a strong proponent of arthroscopic Latarjet. But the companies are more inclined in making the younger surgeons do it just for the sake of using their implants, and it's a sort of marketing for them, and it's a sort of income for them. So I request the young surgeons not to fall prey for this proponents of arthroscopic Latarjet by the companies. Definitely, the other best solution would be using a free bone block, which can be either in the form of ilia crest bone graft, or the more easier one is the scapula spine, which seems to be very practical, sensible, easy to procure, and adding it up along with the labral repair. See, not just using a free bone graft is enough. You need to add the bone graft, fix it with the fiber tape, then over the bone graft, you have to do a capsular repair or the Bankart repair. And together that will act as a very good replacement for Latarjet. And good thing about this procedure, this free bone block procedure, is it does not violate the subscapularis. In arthroscopic Latarjet, you're using the RF probe and tearing through the subscapular muscle, which is absolutely not good for the muscle, because subscap is one of the important anterior dynamic stabilizer. Now, if you use an RF probe and if it heals by fibrosis, then that muscle becomes a dysfunctional, or that part becomes dysfunctional, and invariably you're affecting the shoulder biomechanics, and that should not be done. Whereas in an open procedure, you're not using any cautery, you're just using scissor and opening it up. Okay. So in the thought of doing a minimally invasive procedure, you're actually causing more damage to the soft tissues, which I will not agree with. So if at all you want to do any bone block procedure arthroscopically, I would strongly incline myself towards the free bone block procedure along with the capsular repair, and rather than an arthroscopic Latarjet. Next important thing is doing the dynamic anti-stabilization as an adjuvant has got its own difficulties, because it can be done well only in a V-chair position, not in a lateral decubitus position. So you may have to reposition the patient if you're doing a lateral decubitus, shift them to V-chair, and then add the DAS procedure. So these things will keep evolving, but at present, we do Bankart repair with remplissage, we do open Latarjet, and these two things have been successful for the past 10 years. And let's see what our series says. So far, for the I would say at least for the past 5 to 10 years, we have been successful in our decision making, and I hope this continues in future also.
Yes. Thank you, sir.
Yeah, that's right. You know, whatever the industry brings up, and very often they recycle, because something doesn't work and they do a little modification, and what you do, use the technology and the implants. And I agree with Dr. Shyam. And when you can do open Latarjet beautifully well in about 30-45 minutes, it's really not necessary to go through all that arthroscopic Latarjet and put the patient to possibility of a lot of complications. So one has to think many times if you want to take up. I'm glad we are not doing it, really. And another thing, you know, I always try to go back to fundamentals, and Rohit spoke well, and but I did not hear him once saying about inferior capsular shift. And only in the video that recorded message said inferior capsular shift. But he did not say anything about inferior capsular shift. So what happens is, due to recurrent dislocation, the anterior inferior capsule gets stretched beyond its capability of coming back to the original length. It's a plastic deformation. I don't know how many of you read about this. So when you fix the Bankart lesion, you have to bring the inferior capsule superiorly. This, it's ingrained in my mind because that's what we do, open. Bring it all the way up and fix it to repair anterior recurrent dislocation with Bankart lesion. I hope you fellows will go back and read about inferior capsular shift, which is fundamental, and learn about it. Rohit, I want you to learn and talk to me about it.
Yes, sir. Yes, sir.
You know that you never mentioned even once inferior capsular shift? Yes or no?
Yes, sir. Sorry.
Yes,
sir.
you mentioned. Yes, you mentioned.
No, he didn't mention.
David,
He didn't mention. He's accepting the fact that he didn't mention.
Yeah, just joking.
David and Shyam. David and Shyam, may I insert a thought?
Yes, sir.
This is Gopal.
Yes, Gopal.
I was a resident of Dr. Charles. I was resident of Dr. Charles Sneer, and I couldn't get a fellowship with him at that time because he couldn't afford to give me $100. Be that as it may, the original inferior capsular shift I've seen him do, and if the fellows want to look it up, there is an article by Foster and Neer. Foster was one of the junior residents who followed me at Columbia Presbyterian, and they wrote up the inferior capsular shift after they had done 30 or 40 cases. Originally, when we had the Bankarts with bony laws or off track, on track, whatever, all of them got an inferior capsular shift. This business about arthroscopic Latarjet is going to go away when they find so many complications over time. There is nothing like making a small incision, looking at it, putting the bone graft in, putting the screws in, instead of struggling for 6 hours and giving up and opening.
Absolutely, sir. Totally agree with you. But the problem is, the young shoulder surgeons are terribly diverted towards this fancy procedure. So what makes us in a difficult situation is that these young fellows go out, venture, and then start doing this procedure, put it in the social media saying that I'm doing arthroscopic Latarjet, and we don't know what complication they're going to come up after 2, 3 years or 5 years. So a message for the young guys is, don't get diverted by what the companies propagate. We have a high rate of failure using the fiber tape fixation for arthroscopic Latarjet, which is proposed by the Arthrex company, which has been accepted by Dr. Ayyappan Nair, who is doing arthroscopic Latarjet in Bangalore. And he is given up using fiber tape fixation for arthroscopic Latarjet. He has come back to, again, screw fixation with the DePuy. So if you're happy with open Latarjet, just stick onto it and do it properly. That is more than enough. Nothing beats, in my experience, nothing beats a well done open Latarjet rather than a struggled and improperly done arthroscopic Latarjet.
Thank you, sir.
Always go back to fundamentals and read a little bit of history. You'll be able to do much better.
Yes.
Thank you.
Yes.
Thank you,
Thank
sir.
you.
I think we have come to the end. Dharani Kumar, this is a totally different discussion, glenoid fracture management. Can we do this the next class, if you don't mind?
Okay, sure, sir. Yes, sir.
Yeah,
Shyam, this is Yuvraj, Shyam.
Yes, sir.
Shyam, in your practice, how do you choose between arthroscopic Bankart's repair with remplissage versus Latarjet? What's your indication, Shyam? How do you
Sir, we follow the glenoid track concept to be more simple. We don't follow the subcritical bone loss concept. We just follow the glenoid track concept. If the bone loss is more than 24%, then it's obviously lethargy. If it is less than 24%, we clearly cut check whether it's an on-track or off-track lesion. And then based on the patient's profile, which means contact worker, hardcore labor, military personnel, overhead throwing athlete, contact sports athletes, or people who are involved in getting back to gym activities or swimming, where the shoulder is put to an extra physiological load, not the normal day-to-day load or extra physiological load. We think the shoulder is going to stretch out in spite of doing a good Bankart repair, and the chance of failure is very high. And in those kind of subset of patients, we always advise Latarjet, because the failure rate of a Latarjet is less than 5%. Whereas in these patients, the failure rate of a soft tissue Bankart repair can range up to 60 to 75%. So we are happy in tailor making procedures for patients according to their profile.
Thank you, Sam. Does pre-op size of the coracoid will it decide whether we can go with
Definitely. We
Yeah.
actually the pre-op size of the coracoid you're talking about for the Latarjet?
Yeah.
Yes, we actually had this research way back in 2014, where Dr. Ashwin Vijay wanted to do a research on this, Ashwin Vijay and Geethan. But the problem with the coracoid morphology is not straight, and we don't have a proper software to make the true measurement of whatever coracoid you're going to take for doing the Latarjet. And right now the literature says the minimum length of the coracoid that is needed is 20 millimeters, which is easily achievable for an Indian population. I don't know about the Japanese or the Asian population, but for Indian population, you can procure a 20 millimeters long coracoid graft, which is good enough to accommodate 2 4 mm screws. So if that is possible, then Latarjet is possible, and we are able to do it in all the patients. And in case if this is not possible, now we have the recent advances in the form of the scapula spine, which gives us whatever size graft we need. Or even we can take the iliacrus bone graft, but the scapula spine is good because it is covered in the supraclavicular block, and procuring the graft is hardly a 5-minute step. So that makes our job more easy.
Okay, sure. Thank you.
So we have come to the end of the session. It was a very good discussion. Thanks a lot for emphasizing on the basics, and most of the live surgeries which you see in the conferences, all the live surgeries, they do not stress upon how to do an inferior capsular shift. The surgeon puts the anchor and ties the knot over the labrum, but they do not say how to reinstore the capsular tension. And if you see, DVSR classically explains how you pull back the labrum when you're tying the knot. That is the way you have to reinstate it. So keep that in mind. Don't deviate from the basics. And then we'll discuss about the other factors which are involved in instability in the future classes. Thank you very much. See you soon.
Thank you. Good night, Gopal.
Good night. Good night.
Good night.
Great discussion. I loved it. Good night.
Thanks for joining.